So the left side is the respiratory side. This is stuff that all happens in the lungs. Respiratory acidosis occurs because the lungs aren't removing enough CO2. Often this is the result of hypoventilation, as in an opiate overdose, or COPD or asthma. Respiratory alkalosis is the result of hypoventilation, usually secondary to something like diabetic ketoacidosis, an infection, an MI, or pulmonary embolism. And the right side is the metabolic side. Metabolic acidosis is usually secondary to sepsis, diabetic ketoacidosis, or salicylate poisoning. Metabolic acidosis is an increase in hydrogen ions or a decrease in bicarbonate ions. Essentially, uncompensated acidosis is a lack of bicarb, and uncompensated alkalosis is an overabundance of bicarb. Metabolic alkalosis is actually pretty rare, and mostly results from gastric suctioning. Let's take a moment to look at acidosis and alkalosis more closely. Metabolic acidosis is characterized by an increase in the hydrogen ion concentration of the serum. Because the hydrogen ions vacuum up all of the bicarb, the result is a low serum bicarbonate value, and we can give that a number. It's usually less than 24 milliequivalents per liter. There are four main mechanisms that lead to metabolic acidosis. They are increased production of acid, decreased excretion of acid, ingestion of acid, and renal or gastrointestinal bicarbonate losses. So, blood pH of less than 7.35 with a bicarbonate value of less than 24 milliequivalents per liter is metabolic acidosis. Any further classification is based on the presence or the absence of an anion gap. When we say there's an anion gap, it's just a fancy way of saying that there is a higher than usual amount of lactate or acetoacetate present in the serum. The reason we call it a gap is simply that we don't measure those two anions, the lactate and the acetoacetate. So when we do the blood work that accounts for all the cations and anions that are measured, there is sometimes a missing component, or a gap. We know that the gap exists because we know that plasma is electrically neutral, and the positive charge, which is due mostly to the sodium cations, must balance the negative charge. The negative charge is due to a number of different types of anions, of which bicarbonate and chloride are the major constituents. But some of these anions are not measured normally in blood work, so when they're present, there appears to be more positive charge than negative charge. In other words, there's a gap between the negative and positive charge. Anyway, once you've got that sorted out and decided that it is metabolic acidosis, and you've figured out whether or not there's an anion gap, a non-gap metabolic acidosis is usually due to a loss of bicarbonate. Most often, bicarbonate is lost because of diarrhea and/or renal tubular acidosis. Metabolic acidosis with an anion gap is the result of anaerobic metabolism that leads to an accumulation of lactic acid. There's a bunch of reasons this might happen, and if you're really interested, you can look up the mnemonic cat mud piles. But essentially, that's the story of metabolic acidosis. So respiratory acidosis, as opposed to metabolic acidosis, is caused by a failure of ventilation that leads to an accumulation of carbon dioxide. The additional carbonic acid is carried in the bloodstream and it chews up all of the available bicarb, causing the pH to fall. For respiratory acidosis, the PCO2 is greater than 40 or 45 due to the decreased ventilation. By contrast, metabolic acidosis is due to alterations in bicarbonate, so the PCO2 is less than 40 since it's not the cause of the primary acid-base disturbance. In terms of presentation for either metabolic or respiratory acidosis, you can expect to see CNS depression in the form of lethargy and confusion, and possibly a form of hyperventilation known as Kussmaul respirations, which serve to remove the excess CO2. The management of metabolic acidosis needs to address the cause of the underlying acid-base derangement. For example, adequate fluid resuscitation and correction of the electrolyte abnormalities are necessary for sepsis and diabetic ketoacidosis. Other therapies to consider include antidotes for poisoning, dialysis, antibiotics, and bicarbonate administration in certain situations. In respiratory acidosis, EMS and emergency medicine can make an early contribution because pharmacological therapy can improve ventilation. Bronchodilators like beta agonists, anticholinergic drugs, and methylxanthines like theophylline can all help. And of course, naloxone can be used in opiate overdoses. Just keep in mind that hypercapnia has to be corrected gradually because rapid alkalization of the cerebrospinal fluid can cause seizures. Respiratory alkalosis is usually secondary to hyperventilation. The hyperventilation usually occurs in response to pain, anxiety, hypoxia, increased metabolic demand, or somewhat confusingly, metabolic acidosis. Respiratory alkalosis is not considered life-threatening, although the underlying etiology may be. Alright, that's a lot about acids and bases, and probably enough for now. Let's move on to blood and transfusions.